53613 CUST, Pearson, Berman PG number 486 title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. Lifespan Considerations. Temperature. Infants. The body temperature of newborns is extremely labile, and newborns must be kept warm and dry to prevent hypothermia. Using the axillary sight, you need to hold the infant's arm against the chest, figure 29-10. The axillary route may not be as accurate as other routes for detecting fevers in children. The tympanic route is fast and convenient. Place the infant supine and stabilize the head. Pull the pinna straight back and slightly downward. Remember that the pinna is pulled upward for children over 3 years of age and adults, but downward for children younger than age 3. Direct the probe tip anteriorly and insert far enough to seal the canal. The tip will not touch the tympanic membrane. Avoid the tympanic route in a child with active ear infections or tympanic membrane drainage tubes. The tympanic membrane route may be more accurate in determining temperature in febrile infants. When using a temporal artery thermometer, touching only the forehead or behind the ear is needed. The rectal route is least desirable in infants. Children. Tympanic or temporal artery sites are preferred. For the tympanic route, have the child held on an adult's lap with the child's head held gently against the adult for support. Pull the pinna straight back and upward for children over age 3, figure 29-11. Avoid the tympanic route in a child with active ear infections or tympanic membrane drainage tubes. The oral route may be used for children over age 3, but non-breakable, electronic thermometers are recommended. For a rectal temperature, place the child prone across your lap or in a side-lying position with the knees flexed. Insert the thermometer 2.5 centimeters 1 inch into the rectum. Older adults' temperatures tend to be lower than those of middle-aged adults. Older adults' temperatures are strongly influenced by both environmental and internal temperature changes. Their thermoregulation control processes are not as efficient as when they were younger, and they are at higher risk for both hypothermia and hyperthermia. Older adults can develop significant buildup of ear cerumen, earwax, that may interfere with tympanic thermometer readings. Older adults are more likely to have hemorrhoids. Inspect the anus before taking a rectal temperature. Older adults' temperatures may not be a valid indication of the seriousness of the pathology of a disease. They may have pneumonia or a urinary tract infection and have only a slight temperature elevation. Other symptoms, such as confusion and restlessness, may be displayed and need follow-up to determine if there is an underlying process. Figure 29-10 Axillary thermometer placement for a child. Figure 29-11 Pull the pinna of the ear back and up for placement of a tympanic thermometer in a child over 3 years of age, back and down for children under age 3. Figure 29-12 A pacifier thermometer. Home care considerations. Temperature. Teach the client accurate use and reading of the type of thermometer to be used. Examine the thermometer used by the client in the home for safety and proper functioning. Facilitate the replacement of mercury thermometers with non-mercury ones. See page 482 for instructions regarding management of a broken mercury thermometer. Observe the client/caregiver taking and reading a temperature. Reinforce the importance of reporting the site and type of thermometer used and the value of using the same site and thermometer consistently. Discuss means of keeping the thermometer clean, such as warm water and soap, and avoiding cross-contamination. Ensure that the client has water-soluble lubricant if using a rectal thermometer. Instruct the client or family member to notify the healthcare provider if the temperature is 38.5 degrees Celsius 101.3 degrees Fahrenheit or higher. When making a home visit, take a thermometer with you in case the clients do not have a functional thermometer of their own. Check that the client knows how to record the temperature. Provide a recording chart/table if indicated. Discuss environmental control modifications that should be made during illness or extreme climate conditions, example, heating, air conditioning, appropriate clothing and bedding. Pacifier thermometers, figure 29 to 12, may be used in the home setting for children under 2 years old. The manufacturer's instructions must be followed carefully since many require adding 0.5 degrees Fahrenheit in order to estimate rectal temperature. Patient-centered care. M29B_Berm 4362_10_SE_CH29.IND 486 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 487. Number 153613 CUST, Pearson O. Berman PG Number 487 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Preparations decrease the heart rate, whereas epinephrine increases it. Hypovolemia/dehydration. Loss of blood from the vascular system increases the pulse rate. In adults, the loss of circulating volume results in an adjustment of the heart rate to increase blood pressure, as the body compensates for the lost blood volume. Stress. In response to stress, sympathetic nervous stimulation increases the overall activity of the heart. Stress increases the rate as well as the force of the heartbeat. Fear and anxiety as well as the perception of severe pain stimulate the sympathetic system. Position. When a person is sitting or standing, blood usually pools in dependent vessels of the venous system. Pooling results in a transient decrease in the venous blood return to the heart, and a subsequent reduction in blood pressure and increase in heart rate. Pathology. Certain diseases such as some heart conditions or those that impair oxygenation can alter the resting pulse rate. Pulse sites. A pulse may be measured in 9 sites, figure 29 to 13. 1. Temporal, where the temporal artery passes over the temporal bone of the head. The site is superior, above, and lateral to, away from the midline of, the eye. Pulse. The pulse is a wave of blood created by contraction of the left ventricle of the heart. Generally, the pulse wave represents the stroke volume output, or the amount of blood that enters the arteries with each ventricular contraction. Compliance of the arteries is their ability to contract and expand. When a person's arteries lose their distensible ITY, as can happen with age, greater pressure is required to pump the blood into the arteries. Cardiac output is the volume of blood pumped into the arteries by the heart, and equals the result of the stroke volume, SV, times the heart rate, HR, per minute. For example, 65 ml 370 beats per minute 4.55 L per minute. When an adult is resting, the heart pumps about 5 liters of blood each minute. In a healthy person, the pulse reflects the heartbeat. That is, the pulse rate is the same as the rate of the ventricular contractions of the heart. However, in some types of cardiovascular disease, the heartbeat and pulse rates can differ. For example, a client's heart may produce very weak or small pulse waves that are not detectable in a peripheral pulse far from the heart. In these instances, the nurse should assess the heartbeat and the peripheral pulse. A peripheral pulse is a pulse located away from the heart, for example, in the foot or wrist. The apical pulse, in contrast, is a central pulse, that is, it is located at the apex of the heart. It is also referred to as the point of maximal impulse, PMI. Factors affecting the pulse. The rate of the pulse is expressed in beats per minute, beats/min. A pulse rate varies according to a number of factors. The nurse should consider each of the following factors when assessing a client's pulse. Age. As age increases, the pulse rate gradually decreases overall. See Table 29-2 for specific variations in pulse rates from birth to adulthood. Sex. After puberty, the average male's pulse rate is slightly lower than the female's. Exercise. The pulse rate normally increases with activity. The rate of increase in the professional athlete is often less than in the average person because of greater cardiac size, strength, and efficiency. Fever. The pulse rate increases, A, in response to the lowered blood pressure that results from peripheral vasodilation associated with elevated body temperature, and B, because of the increased metabolic rate. Medications. Some medications decrease the pulse rate, and others increase it. For example, carditonics, example, digitalis. Carotid. Apical brachial. Femoral. Temporal. Radial. Popliteal. Dorsalis pedis. Posterior tibial. Figure 29 to 13-9 sites for assessing pulse. Variations in pulse and respirations by age table 29 to 2. Age pulse average and ranges. Respirations average and ranges. Newborn 130, 80 to 180, 35, 30 to 60. 1 year 120, 80 to 140, 30, 20 to 40, 5 to 8 years 100, 75 to 120, 20, 15 to 25, 10 years 70, 50 to 90, 19, 15 to 25, teen 75, 50 to 90, 18, 15 to 20, adult 80, 60 to 100, 16, 12 to 20, older adult 70, 60 to 100, 16, 15 to 20. M29B_Berm 4362_10_SE_CH29.IND 487 February 12, 14, 5:51 p.m. 488 Unit 7 Assessing Health. Number 153613 CUST, Pearson, Berman PG Number 488 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K/Normal Design Services of S4 Carlisle Publishing Services. 2. Carotid, at the side of the neck where the carotid artery runs between the trachea and the sternocleidomastoid muscle. Clinical alert. Never press both carotids at the same time, because this can cause a reflex drop in blood pressure or pulse rate. Apical pulse before age 4. Apical pulse at ages 4 to 6. Apical pulse in adult body of sternum. Anterior axillary angle of line Lewis. Manubrium of sternum clavicle. Midsternal line midclavicular line. Figure 29 to 14 Location of the apical pulse for a child under 4 years, a child 4 to 6 years, and an adult. 3. Apical, at the apex of the heart. In an adult, this is located on the left side of the chest, about 8 centimeters 3 inches to the left of the sternum, breastbone, at the 5th intercostal space, area between the ribs. In older adults, the apex may be further left if conditions are present that have led to an enlarged heart. Before 4 years of age, the apex is left of the midclavicular line, MCL. Between 4 and 6 years, it is at the MCL, figure 29 to 14. For a child 7 to 9 years of age, the apical pulse is located at the 4th or 5th intercostal space. 4. Brachial, at the inner aspect of the biceps muscle of the arm, or medially in the antecubital space. 5. Radial, where the radial artery runs along the radial bone, on the thumb side of the inner aspect of the wrist. 6. Femoral, where the femoral artery passes alongside the inguinal ligament. 7. Popliteal, where the popliteal artery passes behind the knee. 8. Posterior tibial, on the medial surface of the ankle where the pos. Anterior tibial artery passes behind the medial malleolus. 9. Dorsalis pedis, where the dorsalis pedis artery passes over the bones of the foot, on an imaginary line drawn from the middle of the ankle to the space between the big and second toes. The radial site is most commonly used in adults. It is easily found in most people and readily accessible. Some reasons for use of each site are given in Table 29 to 3. Assessing the pulse. A pulse is commonly assessed by palpation, feeling, or auscultation, hearing. The middle three fingertips are used for palpating all pulse sites, except the apex of the heart. A stethoscope is used for assessing apical pulses. A Doppler ultrasound stethoscope, DUS, figure 29 to 15, is used for pulses that are difficult to assess. The DUS headset has earpieces similar to standard stethoscope earpieces, but it has a long cord attached to a volume-controlled audio unit and an ultrasound transducer. The DUS detects movement of red blood cells through a blood vessel. In contrast to the conventional stethoscope, it eliminates environmental sounds. A pulse is normally palpated by applying moderate pressure with the three middle fingers of the hand. The pads on the most distal aspects of the finger are the most sensitive areas for detecting a pulse. With excessive pressure, one can obliterate a pulse, whereas with too little pressure one may not be able to detect it. Before the nurse assesses the resting pulse, the client should assume a comfortable position. The nurse should also be aware of the following: any medication that could affect the heart rate, whether the client has been physically active. If so, wait 10 to 15 minutes until the client has rested and the pulse has slowed to its usual rate. Figure 29 to 15, a Doppler ultrasound stethoscope, DUS. Pulse site reasons for use: radial readily accessible temporal used when radial pulse is not accessible, carotid used during cardiac arrest/shock in adults, used to determine circulation to the brain, apical routinely used for infants and children up to 3 years of age, used to determine discrepancies with radial pulse, used in conjunction with some medications, brachial used to measure blood pressure, used during cardiac arrest for infants, femoral used in cases of cardiac arrest/shock. Used to determine circulation to a leg, popliteal, used to determine circulation to the lower leg, posterior tibial, used to determine circulation to the foot, dorsalis pedis, used to determine circulation to the foot. Reasons for using specific pulse site, table 29 to 3. M29B_Berm 4362_10_SE_CH29.IND 488 February 12, 5:51 p.m. Chapter 29, Vital Signs 489. Number 153613 CUST, Pearson, Berman PG. Number 489. Title, Kosier and Herbs, Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Obliterated with greater pressure. A forceful or full blood volume that is obliterated only with difficulty is called a full or bounding pulse. A pulse that is readily obliterated with pressure from the fingers is referred to as weak, feeble, or thready. The elasticity of the arterial wall reflects its expansibility or its deformities. A healthy, normal artery feels straight, smooth, soft, and pliable. Older adults often have inelastic arteries that feel twisted, tortuous, and irregular on palpation. When assessing a peripheral pulse to determine the adequacy of blood flow to a particular area of the body, perfusion, the nurse should also assess the corresponding pulse on the other side of the body. The second assessment gives the nurse data with which to compare the pulses. For example, when assessing the blood flow to the right foot, the nurse assesses the right dorsalis pedis pulse and then the left dorsalis pedis pulse. If the client's right and left pulses are the same volume and elasticity, the client's dorsalis pedis pulses are bilaterally equal. The pulse rate does not need to be counted when assessing for perfusion and equality. When a peripheral pulse is located, it indicates that pulses more proximal to that location will also be present. For example, if the dorsalis pedis, the most distal pulse of the lower extremity, cannot be felt, the nurse next palpates for the posterior tibial pulse. If it is not felt, the popliteal pulse must be assessed. If the popliteal pulse is found, it is not necessary to assess the femoral pulse, since it must also be present in order for the more distal pulse to exist. Skill 29-2 provides guidelines for assessing a peripheral pulse. Any baseline data about the normal heart rate for the client. For example, a physically fit athlete may have a resting heart rate below 60 beats/min. Whether the client should assume a particular position, example, sitting. In some clients, the rate changes with the position because of changes in blood flow volume and autonomic nervous system activity. When assessing the pulse, the nurse collects the following data: the rate, rhythm, volume, arterial wall elasticity, and presence or absence of bilateral equality. An excessively fast heart rate, example, over 100 beats/min in an adult, is referred to as tachycardia. A heart rate in an adult of less than 60 beats/min is called bradycardia. If a client has either tachycardia or bradycardia, the apical pulse should be assessed. The pulse rhythm is the pattern of the beats and the intervals between the beats. Equal time elapses between beats of a normal pulse. A pulse with an irregular rhythm is referred to as a dysrhythmia or arrhythmia. It may consist of random, irregular beats, or a predictable pattern of irregular beats, documented as regularly irregular. When a dysrhythmia is detected, the apical pulse should be assessed. An electrocardiogram, ECG, is necessary to define the dysrhythmia further. Pulse volume, also called the pulse strength or amplitude, FERS to the force of blood with each beat. Usually, the pulse volume is the same with each beat. It can range from absent to bounding. A normal pulse can be felt with moderate pressure of the fingers and can be purposes to establish baseline data for subsequent evaluation to identify whether the pulse rate is within normal range to determine the pulse volume, and whether the pulse rhythm is regular to determine the equality of corresponding peripheral pulses on each side of the body. Assessment: assess clinical signs of cardiovascular alterations such as dyspnea, difficult respirations, fatigue, pallor, cyanosis, bluish discoloration of skin and mucous membranes, palpitations, syncope, fainting, or impaired peripheral tissue perfusion, as evidenced by skin discoloration and cool temperature. Planning delegation. Measurement of the client's radial or brachial pulse can be delegated to UAP, or be performed by family members/caregivers in non-hospital settings. Reports of abnormal pulse rates or rhythms require reassessment by the nurse, who also determines appropriate action if the abnormality is confirmed. UAP are generally not delegated these techniques due to the skill required in locating and interpreting peripheral pulses other than the radial or brachial artery, and in using Doppler ultrasound devices. Equipment: clock or watch with a sweep second hand or digital seconds indicator. To monitor and assess changes in the client's health status. To monitor clients at risk for pulse alterations, example, those with a history of heart disease or experiencing cardiac arrhythmias, hemorrhage, acute pain, infusion of large volumes of fluids, or fever, to evaluate blood perfusion to the extremities. Factors that may alter pulse rate, example, emotional status and activity level, which site is most appropriate for assessment based on the purpose. Interprofessional practice. Assessing a peripheral pulse may be within the scope of practice for many healthcare providers. For example, in addition to nurses, both physical therapists and respiratory therapists may check the client's pulse before, during, and after treatment. Although these therapists may verbally communicate their findings and plan to the healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. If using a DUS, transducer probe, stethoscope headset, some models, transmission gel, and tissue/wipes. Assessing a peripheral pulse. Skill 29-2. Continued on page 490. M29B_Berm 4362_10_SE_CH29.IND 489 February 12, 14, 5:51 p.m. 490 Unit 7 Assessing Health. Number 153613 CUST, Pearson, Berman PG Number 490 Title, Kosier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. 2. Perform hand hygiene and observe appropriate infection prevention procedures. 3. Provide for client privacy. 4. Select the pulse point. Normally, the radial pulse is taken, unless it cannot be exposed or circulation to another body area is to be assessed. 5. Assist the client to a comfortable resting position. When the radial pulse is assessed, with the palm facing downward, the client's arm can rest alongside the body, or the forearm can rest at a 90-degree angle across the chest. For the client who can sit, the forearm can rest across the thigh, with the palm of the hand facing downward or inward. 6. Palpate and count the pulse. Place 2 or 3 middle fingertips lightly and squarely over the pulse point. Implementation preparation. If using a DUS, check that the equipment is functioning normally. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. Assessing pulses, A radial, B brachial. C carotid. D femoral. E popliteal, F posterior tibial. Assessing a peripheral pulse, continued. Skill 29-2. M29B_Berm 4362_10_SE_CH29.IND 490 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 491. Number 153613 CUST, Pearson, Berman PG Number 491 Title, Kosier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing a peripheral pulse, continued. Skill 29-2. Rationale. Using the thumb is contraindicated because the nurse's thumb has a pulse that could be mistaken for the client's pulse. Count for 15 seconds and multiply by 4. Record the pulse in beats per minute on your worksheet. If taking a client's pulse for the first time, when obtaining baseline data, or if the pulse is irregular, count for a full minute. If an irregular pulse is found, also take the apical pulse. 7. Assess the pulse rhythm and volume. Assess the pulse rhythm by noting the pattern of the intervals between the beats. A normal pulse has equal time periods between beats. If this is an initial assessment, assess for 1 minute. Assess the pulse volume. A normal pulse can be felt with moderate pressure, and the pressure is equal with each beat. A forceful pulse volume is full, an easily obliterated pulse is weak. Record the rhythm and volume on your worksheet. 8. Document the pulse rate, rhythm, and volume and your actions. In the client record, see figure in Skill 29-1. Also record in the nurse's notes pertinent related data, such as variation in pulse rate, compared to normal, for the client, and abnormal skin color and skin temperature. Variation, using a DUS if used. Plug the stethoscope headset into one of the 2 output jacks located next to the volume control. DUS units may have 2 jacks so that a second person can listen to the signals. Apply transmission gel either to the probe at the narrow end of the plastic case housing the transducer, or to the client's skin. Rationale: ultrasound beams do not travel well through air. The gel makes an airtight seal, which then promotes optimal ultrasound wave transmission. Press the on button. Hold the probe against the skin over the pulse site. Use a light pressure, and keep the probe in contact with the skin. Rationale: too much pressure can stop the blood flow and obliterate the signal. Adjust the volume if necessary. Distinguish artery sounds from vein sounds. The artery sound, signal, is distinctively pulsating, and has a pumping quality. The venous sound is intermittent and varies with respirations. Both artery and vein sounds are heard simultaneously through the DUS, because major arteries and veins are situated close together throughout the body. If arterial sounds cannot be easily heard, reposition the probe. If you can not hear any pulse, move the probe to several different locations in the same area before determining that no pulse is present. After assessing the pulse, remove all gel from the probe to prevent damage to the surface. Clean the transducer with water-based solution. Rationale: alcohol or other disinfectants may damage the face of the transducer. Remove all gel from the client. Using a DUS to assess the posterior tibial pulse. Evaluation: compare the pulse rate to baseline data, or normal range for age of client. Relate pulse rate and volume to other vital signs. Relate pulse rhythm and volume to baseline data and health status. If assessing peripheral pulses, evaluate equality, rate, and volume in corresponding extremities. Conduct appropriate follow-up, such as notifying the primary care provider or giving medication. G. dorsalis pedis. Apical pulse assessment. Assessment of the apical pulse is indicated for clients whose peripheral pulse is irregular or unavailable, and for clients with known cardiovascular, pulmonary, and renal diseases. It is commonly assessed prior to administering medications that affect heart rate. The apical site is also used to assess the pulse for newborns, infants, and children up to 2 to 3 years old. Skill 29-3 presents guidelines for assessing the apical pulse. M29B_Berm 4362_10_SE_CH29.IND 491 February 12, 14, 5:51 p.m. 492 Unit 7 Assessing Health. Number 153613 CUST, Pearson, Berman PG. Number 492 Title, Kosier and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing an apical pulse. Skill 29-3. Purposes: to obtain the heart rate of an adult with an irregular peripheral pulse to establish baseline data for subsequent evaluation. To determine whether the cardiac rate is within normal range and the rhythm is regular, to monitor clients with cardiac, pulmonary, or renal disease, and those receiving medications to improve heart action. Assessment: assess clinical signs of cardiovascular alterations such as dyspnea, difficult respirations, fatigue/weakness, pallor, cyanosis, bluish discoloration of skin and mucous membranes, palpitations, syncope, fainting, or impaired peripheral tissue perfusion as evidenced by skin discoloration and cool temperature. Factors that may alter pulse rate: example, emotional status, activity level, and medications that affect heart rate such as digoxin, beta blockers, or calcium channel blockers. Planning delegation. Due to the degree of skill and knowledge required, UAP are generally not responsible for assessing apical pulses. Equipment: clock or watch with a sweep, second hand or digital seconds indicator, stethoscope, antiseptic wipes if using a DUS, the transducer probe, the stethoscope headset, transmission gel, and tissues/wipes. Interprofessional practice. Assessing an apical pulse may be within the scope of practice for many healthcare providers. For example, in addition to nurses, respiratory therapists may check the client's apical pulse before, during, and after treatment, and physicians often check the apical pulse when assessing the chest during examinations. Although these providers may verbally communicate their findings and plan to other healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Second intercostal space. Shirley Snyder. Implementation preparation: if using a DUS, check that the equipment is functioning normally. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe appropriate infection prevention procedures. 3. Provide for client privacy. 4. Position the client appropriately in a comfortable supine position, or in a sitting position. Expose the area of the chest over the apex of the heart. 5. Locate the apical impulse. This is the point over the apex of the heart, where the apical pulse can be most clearly heard. Palpate the angle of Lewis, the angle between the monobrium, the top of the sternum, and the body of the sternumber. It is palpated just below the suprasternal notch, and is felt as a prominence, see figure 29 to 14. Slide your index finger just to the left of the sternum and palpate the second intercostal space. Clinical alert. When left and right are used to describe the nurse's hand placement on the client, the terms refer to the client's right or left side, not the nurse's. Place your middle or next finger in the third intercostal space, and continue palpating downward until you locate the fifth intercostal space. Move your index finger laterally along the fifth intercostal space toward the MCL. Normally, the apical impulse is palpable at or just medial to the MCL, see figure 29 to 14. 6. Auscultate and count heartbeats. Use antiseptic wipes to clean the earpieces and diaphragm of the stethoscope. Rationale: the diaphragm needs to be cleaned and disinfected if soiled with body substances. Both earpieces and diaphragms have been shown to harbor pathogenic bacteria, Muniz, Sethi, Zaghi, Zinial, and Sandora, 2012. M29B_Berm 4362_10_SE_CH29.IND 492 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 493. Number 153613 CUST, Pearson, Berman PG Number 493 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Continued on page 494. Assessing an apical pulse, continued. Skill 29 to 3. Third intercostal space. Shirley Snyder. Warm the diaphragm of the stethoscope by holding it in the palm of the hand for a moment. Rationale: the metal of the diaphragm is usually cold and can startle the client when placed immediately on the chest. Insert the earpieces of the stethoscope into your ears in the direction of the ear canals, or slightly forward. Rationale: this position facilitates hearing. Tap your finger lightly on the diaphragm. Rationale: this is to be sure it is the active side of the head. If necessary, rotate the head to select the diaphragm side. Place the diaphragm of the stethoscope over the apical impulse, and listen for the normal S1 and S2 heart sounds, which are heard as lub-dub. Rationale: the heartbeat is normally loudest over the apex of the heart. Each lub-dub is counted as one heartbeat. Rationale: the two heart sounds are produced by closure of the heart valves. The S1 heart sound, lub, occurs when the atrioventricular valves close after the ventricles have been sufficiently filled. The S2 heart sound, dub, occurs when the semilunar valves close after the ventricles empty. If you have difficulty hearing the apical pulse, ask the supine client to roll onto his or her left side, or the sitting client to lean slightly forward. Rationale: this positioning moves the apex of the heart closer to the chest wall. If the rhythm is regular, count the heartbeats for 30 seconds and multiply by 2. If the rhythm is irregular or for giving certain medications, such as digoxin, count the beats for 60 seconds. Fifth intercostal space, MCL. Shirley Snyder. Taking an apical pulse using the flat disc stethoscope. Note how the amplifier is held against the chest. Rationale: a 60-second count provides a more accurate assessment of an irregular pulse than a 30-second count. 7. Assess the rhythm and the strength of the heartbeat. Assess the rhythm of the heartbeat by noting the pattern of intervals between the beats. A normal pulse has equal time periods between beats. Assess the strength, volume, of the heartbeat. Normally, the heartbeats are equal in strength, and can be described as strong or weak. A. Stethoscope with both a bell and a diaphragm. B. Close-up of a bell, left, and a diaphragm, right. A. B. M29B_4362_10_SE_CH29.IND493 February 12, 14, 5:51 p.m. 494 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 494 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing an apical pulse, continued. Skill 29-3. 8. Document the pulse rate and rhythm, and nursing actions in the client record. Also record pertinent related data, such as variation in pulse rate, compared to normal, for the client, and abnormal skin color and skin temperature. Sample documentation. February 24, 16 1000 radial pulse 116 and irregular. Had been 82 and regular at 0600. TR and BP within client's usual range. C/O being a little dizzy. Skin warm and dry. Apical pulse 120, irregular, with brief pause after Q third beat. MD notified and ECG ordered. _______________________________G Chapman, RN. Evaluation. Relate the pulse rate to other vital signs. Relate the pulse rhythm to baseline data and health status. Report to the primary care provider any abnormal findings such as irregular rhythm, reduced ability to hear the heartbeat, pallor, cyanosis, dyspnea, tachycardia, or bradycardia. Conduct appropriate follow-up such as administering medication ordered based on apical heart rate. Apical radial pulse assessment. An apical radial pulse may need to be assessed for clients with certain cardiovascular disorders. Normally, the apical and radial rates are identical. An apical pulse rate greater than a radial pulse rate can indicate that the thrust of the blood from the heart is too weak for the wave to be felt at the peripheral pulse site, or it can indicate that vascular disease is preventing impulses from being transmitted. Any discrepancy between the two pulse rates is called a pulse deficit and needs to be reported promptly. In no instance is the radial pulse greater than the apical pulse. An apical radial pulse can be taken by two nurses or one nurse, although the two-nurse technique may be more accurate. Skill 29-4 outlines the steps for assessing an apical radial pulse. Lifespan considerations. Pulse. Infants use the apical pulse for the heart rate of newborns, infants, and children 2 to 3 years old to establish baseline data for subsequent evaluation, to determine whether the cardiac rate is within normal range, and to determine if the rhythm is regular. Place a baby in a supine position, and offer a pacifier if the baby is crying or restless. Crying and physical activity will increase the pulse rate. For this reason, take the resting apical pulse rate of infants and small children before assessing body temperatures. Locate the apical pulse in the left fourth intercostal space, lateral to the midclavicular line during infancy. Brachial, popliteal, and femoral pulses may be palpated. Due to a normally low blood pressure and rapid heart rate, infants' other distal pulses may be hard to feel. Newborn infants may have heart murmurs that are not pathologic, but reflect functional incomplete closure of fetal heart. Structures, ductus arteriosus or foramen ovale. Children. To take a peripheral pulse, position the child comfortably in the adult's arms or have the adult remain close by. This may decrease anxiety and yield more accurate results. To assess the apical pulse, assist a young child to a comfortable supine or sitting position. Demonstrate the procedure to the child using a stuffed animal or doll, and allow the child to handle the stethoscope before beginning the procedure. This will decrease anxiety and promote cooperation. The apex of the heart is normally located in the left fourth intercostal space in young children, fifth intercostal space in children 7 years of age and over, between the MCL and the anterior axillary line, see figure 29-14. Count the pulse prior to other uncomfortable procedures so that the rate is not artificially elevated by the discomfort. Older adults. If the client has severe hand or arm tremors, the radial pulse may be difficult to count. Cardiac changes in older adults, such as decrease in cardiac output, sclerotic changes to heart valves, and dysrhythmias, may suggest that obtaining an apical pulse will be more accurate than a peripheral pulse. Older adults often have decreased peripheral circulation. To detect these, pedal pulses should also be checked for regularity, volume, and symmetry. The pulse returns to baseline after exercise more slowly than with other age groups. M29B_Berm 4360-10_SE_CH29.IND 494 February 12, 14, 5:51 p.m. Number 153613 CUST, Pearson, Berman PG Number 495 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing an apical radial pulse. Skill 29-4 Assessment. Assess clinical signs of hypovolemic shock, hypotension, pallor, cyanosis, and cold, clammy skin. Planning delegation. UAP are generally not responsible for assessing apical radial pulses using the one-nurse technique. UAP may perform the radial pulse count for the two-nurse technique. Interprofessional practice. Assessing an apical radial pulse may be within the scope of practice for many healthcare providers. Any provider who assesses a pulse can serve as the second person in the two-person technique. Equipment: clock or watch with a sweep, second hand or digital seconds indicator, stethoscope, antiseptic wipes. Implementation preparation. If using the two-nurse technique, ensure that the other nurse is available at this time. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe appropriate infection prevention procedures. 3. Provide for client privacy. 4. Position the client appropriately. Assist the client to a comfortable supine or sitting position. Expose the area of the chest over the apex of the heart. If previous measurements were taken, determine what position the client assumed, and use the same position. Rationale: this ensures an accurate comparative measurement. 5. Locate the apical and radial pulse sites. In the two-nurse technique, one nurse locates the apical impulse by palpation, or with the stethoscope, while the other nurse palpates the radial pulse site. See Skills 29-2 and 29-3. 6. Count the apical and radial pulse rates. Two-nurse technique: place the clock or watch where both nurses can see it. The nurse who is taking the radial pulse may hold the watch. Decide on a time to begin counting. A time when the second hand is on 12, 3, 6, or 9, or an even number on digital clocks is usually selected. The nurse taking the radial pulse says start. Rationale: this ensures that simultaneous counts are taken. Each nurse counts the pulse rate for 60 seconds. Both nurses end the count when the nurse taking the radial pulse says stop. Rationale: a full 60-second count is necessary for accurate assessment of any discrepancies between the two pulse sites. The nurse who assesses the apical rate also assesses the apical pulse rhythm and volume, i.e., whether the heartbeat is strong or weak. If the pulse is irregular, note whether the irregular beats come at random or at predictable times. The nurse assessing the radial pulse rate also assesses the radial pulse rhythm and volume. One nurse technique: within a few minutes, assess the apical pulse for 60 seconds and assess the radial pulse for 60 seconds. 7. Document the apical and radial, AR, pulse rates, rhythm, volume, and any pulse deficit in the client record. Also record related data such as variation in pulse rate compared to normal for the client, and other pertinent observations, such as pallor, cyanosis, or dyspnea. Evaluation relate pulse rate and rhythm to other vital signs, to baseline data, and to general health status. Report to the primary care provider any changes from previous measurements, or any discrepancy between the two pulse rates. Purpose to determine adequacy of peripheral circulation, or presence of pulse deficit. Home care considerations. Pulse. Assist in obtaining and using an electronic pulse measuring device if indicated. Teach the client to monitor the pulse prior to taking medications that affect the heart rate. Tell the client to report any notable changes in heart rate or rhythm, regularity, to the healthcare provider. Inform the client/family of activities known to significantly affect pulse rate, such as emotional stress, exercise, ingesting caffeine, and sleep. Clients sensitive to pulse rate changes should consider whether any of these activities should be modified in order to stabilize the pulse. Some clients require lengthy monitoring of the pulse and cardiac pattern, electrocardiogram. A special device, often referred to as a Holter monitor, is used for this type of monitor. It is usually applied in an office or clinic setting, and the client wears the portable recorder for 24 hours. Other portable devices used for recording episodic arrhythmias include cardiac event monitors. The client activates the device during times when symptoms appear, and then the recorded data can be transmitted to a central location through a telephone. Patient-centered care. 495. M29B_Berm 4362_10_SE_CH29.IND 495 February 12, 14, 5:51 p.m. 496 Unit 7 Assessing Health. Number 153613 CUST, Pearson O. Berman PG Number 496 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Drug capsule. Client with cardiac medications that affect heart rate. Cardiac glycosides increase cardiac contractility, which increases cardiac output. As a result, perfusion to the kidneys is increased, which increases the production of urine. Cardiac glycosides also decrease heart rate by prolonging cardiac conduction, especially at the AV node. Digoxin is commonly used for the clinical management of heart failure, atrial fibrillation, atrial flutter, and paroxysmal atrial tachycardia. Nursing responsibilities. Take the apical pulse for 1 minute before administering the dose. If the apical pulse is 60 beats/min, or another specific parameter set by the healthcare provider, do not administer the dose and retake the pulse in 1 hour. If pulse remains 60, call the prescriber. Note, if the initial resting pulse is significantly 60, or the client has symptoms of bradycardia such as dizziness, notify the primary care provider without waiting to retake. Monitor electrolyte levels. Low potassium and low magnesium and high levels of calcium place the client at risk for digitalis toxicity. Check the client's most recent electrolyte laboratory work for safe levels before administering the dose. Avoid giving with meals because this will delay absorption. Monitor for therapeutic drug levels, 0.5 to 2 nanograms per milliliter. Digoxin has a narrow therapeutic index, which means that there is not much difference between a therapeutic effect and a toxic effect. Assess for signs of digoxin toxicity: anorexia, nausea, vomiting, diarrhea, blurred or yellow vision, unusual tiredness and weakness. Client and family teaching. Explain the reason for taking digoxin and the importance of medical checkups that may include laboratory work to evaluate the effects and dosage of the drug. Teach the client and/or family how to check the radial or carotid pulse for a full minute. Inform them to take the pulse at the same time each day and to write it on the calendar. Provide pulse parameters and tell them when it is appropriate to call the healthcare provider. Caution the client not to stop taking the digoxin without approval of the healthcare provider. Caution the client to avoid over-the-counter drugs, except on the advice of the healthcare provider, because many can interact with digoxin. Explain the signs and symptoms of digoxin toxicity, and the importance of calling the healthcare provider. Note: prior to administering any medication, review all aspects with a current drug handbook or other